Hi, everybody. My name is Nicholas Hornstein. I'm an assistant professor of GI medical oncology at Northwell Health, and I'm really excited today to talk here at the OncoAlert Colloquium 2026. I'm going to be focusing on the year of upper GI. So 2025, we're going to be looking at some of the practice impacting studies we've seen come out across the last year. Now, as many of you have been following along, most of these are in the upper GI space. So we have Matterhorn to start us off. So that's durvalumab and FLOT as the new standard of care for resectable gastroesophageal junction cancer. We have Destiny Gastric 04, which confirmed TDXD as the preferred second line option for HER2 positive gastroesophageal cancers. And then finally, we have some new data that just came out a few weeks ago, Horizon GA01. And while this isn't practice changing yet, because there's no FDA approval, we do expect that this is going to be practice changing with zanidatamab potentially replacing trastuzumab for HER2 positive metastatic gastroesophageal cancers. And if you notice there's a lot of gastroesophageal here, it's true. This was billed as upper GI plus HCC, but just given the studies that have come out over the last year and the fact that I only have 15 minutes to talk about this, it's focusing a little bit more on gastroesophageal. So let's dig in. So to start off, I wanted to start with a roadmap so we can look at kind of how things have developed over the last few years. So starting in 2021, we had Checkmate 649, which added on nivolumab to first-line HER2 negative metastatic gastroesophageal cancer. Fast forward 2023, Keynote 859, Pembro joins the party. We have another PD-1 option here. Same disease, same setting, metastatic. We have Claudin inhibitors come on scene, and it's always amazing to have new targets, new agents, new things to discuss and think about. So we have Claudin 18.2 introduced as a new biomarker with Spotlight and Glow. And then in 2024, we're now showing with Keynote 811 that PD-1s have benefit in HER2 positive disease. Now, remember, these are all in the metastatic setting. Now in 2025 through to 2026, we're seeing things like Matterhorn come out, which are massively changing the standard of care for a huge number of patients. We have Destiny Gastric 04 and Horizon GA01. So let's dig into each of these studies, break down what they are, how they change practice, and some of the pearls for how we're introducing them clinically. What do we watch out for? What are the toxicities? How do we make patient lives a little bit better? So, Matterhorn. Perioperative durvalumab in gastric and gastroesophageal junction cancer. This was a large phase 3 trial. About 900 patients were enrolled that looked at adding on perioperative durvalumab, a PD-1 inhibitor, to the standard of care FLOT. So durvalumab in arm A, placebo in arm B. These patients get treated for 2 cycles, go on to surgery, have adjuvant therapy with durvalumab, and then have some maintenance along the way for about 10 months. So in total, about a year of PD-1 inhibition. And this is added on to our standard backbone of FLOT, which should be familiar with everyone. Pretty toxic, we know that, but it's what we have for resectable gastric and gastroesophageal cancer. In terms of inclusion and exclusion criteria, the major things, well, they can't really be metastatic. I will note that they allow 4A patients in. And now remember, 4A for gastric is different than many other diseases where we expect to see solid organ metastasis. So because of the risk in gastric and gastroesophageal cancer, 4A is T2 or higher or N plus. So for this study. Treatment naive, good functional status. We know that with FLOT, we need people that are going to be up to the task of tolerating it. And they had central PD-L1 testing, which is important to note. Exclusion, true distant organ or peritoneal metastasis. Histologies other than adenocarcinoma were not included. This is a major caveat. Autoimmune things, don't give PD-1s to people with raging autoimmune disease, and then significant morbidity. So what do we see? Well, disease-free survival, there is a significant benefit. It's actually not reached at this follow-up for Durva plus FLOT, hazard ratio of 0.71 with continued separation of the curves. Looks like this is a benefit. It looks like it is helping people. Is it saving lives? Yeah, probably. We're seeing that this is also reaching significance, maturing, number needed to treat about 20 for survival, which is still pretty good. And it looks like pathologic complete response is one of the primary drivers to improved outcomes here, which is just an interesting tidbit. When we go on to subgroup analysis, one of the things that I think is important to reflect on is the relevance of PD-L1 staining. So this was approved for all comers. PD-1 and PD-L1. If you don't have it, fine. If you have it, great. So what we can see going through this data is that there is significance for the subgroup of PD-L1 positive. There is not significance for PD-L1 negative, but if you look at the number of patients in that arm, there's only 47 of them compared to 427. So we know this confidence interval would shrink if we had 427 patients. Either way, most people are using durvalumab across the board, regardless of PD-L1 status. So important to keep that in mind. How does this change practice? First off, yes, it does. The rise of deflot, it's here. Flot should no longer be the default. Deflot is what people should be thinking about unless they have a reason not to give it, such as a patient has significant autoimmune conditions. What do you have to watch for? Well, the standard PD-1 toxicities. I feel like in most people's practices, we've incorporated PD-1s on some level. So we watch out for things like pneumonitis, colitis. And remember, the timing of these immune-related toxicities is going to be a little bit different than what you will see with your standard diarrhea from flot. So teasing them apart, this diarrhea gets worse. It doesn't get better even as you're ending a cycle. So you just keep an eye for it. We know we can manage these with steroids and potentially with biologics. So Destiny Gastric 04 is our next study. So this was TDXD for HER2 positive second-line metastatic gastric and gastroesophageal cancer after progression on a trastuzumab-containing regimen. This was compared against ramucirumab and paclitaxel, the current favored second-line regimen. These patients were randomized 1-to-1, and there's about 500 patients. So another big phase 3 practice-changing study leading us into 2026. This was for adenocarcinoma specifically and HER2 positive, defined as IHC 3+ or IHC 2+ with ISH positivity. And as I mentioned, you must have gotten at least one line of trastuzumab containing therapy before this. In terms of exclusion criteria, history of ILD, we know that there's some concern about ILD development with TDXD, so something to keep in mind. Also watching for cardiac risk. They did allow for some patients with, how do I say this, GI disorders, but they said clinically significant bleeding, perforation risk, you're out. And that's really, I think, because of the ramucirumab inclusion here. Brain metastases that were untreated were also excluded. So what do we see? Disease-free survival, progression-free survival, I should say. TDXD improved progression-free survival compared to RAM-PAC. Really worth pointing out, this is a chemotherapy-free regimen. We'll talk about the toxicities, but that's a huge step forward. I love the fact that we're moving towards a biomarker-selected therapy and then potentially even saving RAM-PAC for down the line. So I don't think you're losing much here if you're going to this. Does it help overall survival? Similar impact. There's a notable tail here as well, which is worth thinking about. It's about a 3-month improvement, but it's still a step forward. We've broken through the 1-year median overall survival for second-line HER2 positive metastatic gastroesophageal cancer and gastric cancer, which is fantastic. Looking at toxicity, nausea, nausea, nausea. Anyone that has used this in the GI or breast space or hepatobiliary space will be familiar with this. You know, we think we have a targeted therapy that has a great payload, but we're still getting nausea as a very significant side effect. Now, what I'll point out is any grade is very high for TDXD. Severe greater than or equal to grade 3 is relatively low at 5%, but patients will complain about this. Make sure you have prophylaxis on. Make sure we're giving the appropriate anti-nausea treatments with TDXD to try to decrease this. Because at the end of the day, if our patients' lives suck, we're not doing the right thing. So just something to watch out for and something we can absolutely control with triple antiemetic therapy. In terms of outcomes, the PFS benefit is a little bit different. Endpoint of overall survival at 24 months, 29% versus 14%. That's huge. Looking at how this is driven, many patients are having partial responses differentially. That's what's really pushing things towards. So you can expect to see some radiographic response, which is also fantastic. How does this change practice? First off, yes, it does. That's why we're talking about it. This changes practice today. Second line should be going either onto a clinical trial or to TDXD instead of RAM-PAC. Now, the HER2 wars are occurring. There are a huge number of HER2 targeted therapies in development right now. Many of them are in phase 3 clinical trials. So TBD, how long this will stay in the second line. It may be that things are moving to the first line. It may be that there are other alternative agents that are coming in that we're going to need to compare to, such as zanidatamab, which is a bispecific antibody we'll talk about for the next study. What you should be watching for, nausea, nausea, nausea. There's a question though, should we repeat HER2 testing? There's some interesting work out by Tim Brown and some others. It looks like HER2 testing might need to be repeated. It's a bit protean and it changes in response to therapy. So you may want to keep in the back of your head, it's worth getting another biopsy looking into HER2 status at the time of progression. Now, moving quickly into Horizon GEA-01. This was just presented, new data, GI ASCO. Zanidatamab and HER2 positive metastatic gastric and gastroesophageal junction cancer. This is a bispecific antibody, and there are 3 arms to this study. There is the control arm of trastuzumab plus chemo, there is zanidatamab plus chemo, and then there is zanidatamab plus tislelizumab plus chemo. Tislelizumab is a PD-1 inhibitor, so yes, there are many of them, but just remember, PD-1 inhibitor. Let's talk a little bit about inclusion-exclusion criteria. This was for unresectable, locally advanced, or recurrent or metastatic GEJ gastric adenocarcinoma. HER2 testing was centrally done, defined as IHC 3+ or 2+ plus ISH. No prior treatments. So, treatment naive. Remember, we just talked about a second-line treatment post-TDXD in Destiny GO04. Horizon GA01 is bringing this in to first line. So, exclusion criteria. No prior treatment with any HER2-containing therapy. Cardiac function with EF less than 50%. Similarly, CNS disease, autoimmune disease. And then esophageal adenocarcinoma that was amenable to definitive chemo-RT was also not included. And what do we see? Well, those are some pretty clear separation of the curves with basically a doubling of the percentage of patients that had progression-free survival between 15.6 and 38.2%, 24 months. This shows some clear improvement comparing Zani plus Tisli plus chemotherapy versus trastuzumab plus chemotherapy. And we have a PFS greater than 1 year. Fantastic. Overall survival similarly has increased. This is greater than 2 years now, 26 months, which is fantastic. And this is compared to 19.2 months with a hazard ratio of 0.72. Now, here's a big question a lot of people are talking about and thinking about. Zani plus Tisli plus chemo versus trastuzumab plus chemo. We're comparing 3 classes of agents to 2 classes of agents. 3 is more than 2. We would expect to see improvement. Is that lack of a PD-1 in the control arm troubling? To some people, a little bit. But honestly, when I'm seeing improvements for survival above 2 years, I'm not going to look a gift horse in the mouth. Once this is FDA approved, which it's not yet, this will become my standard of care in this disease space. That's just me. I think there's a lot of thoughts about it. But at the end of the day, when this trial was designed, the PD-1 was not the appropriate control agent. Could it have been amended? Maybe, but then you have issues with data integrity. Toxicity. So we're watching for non-infectious pulmonary toxicities and immune-related toxicities because we're adding on that PD-1 agent. That is a little bit high, but remember, these were toxicities of any grade. So even a little bit of itchy rash, hypothyroidism might be put into these buckets. So diarrhea, diarrhea, diarrhea. I'm going to show you on the next slide. So the Zani-containing regimens have basically doubled the diarrhea rate. This usually occurs in the first cycle within about 8 days of treatment. Really got to prepare patients prophylactic loperamide, which I don't say often, but they should have it in their hand, ready to go. Giving Zani for the first time, expect to see diarrhea, prepare your patients, give them the treatments they need, and maybe even start them ahead of time because they're probably going to have some diarrhea. In terms of outcomes, we're seeing actually quite surprisingly that the PD-L1 status is not totally associated. Less than 1% seems to have favor here. Little confusing there. This is something to keep an eye on. At the end of the day, we're seeing the signal across the board, though, in terms of the PFS and OS curves. So keep this in the back of the mind, file it back. Maybe we'll see some updates on this. IHC 3+ seems to do a bit better than 2+, but again, look at the numbers. It's 250 patients versus 50 in that arm. Altogether, how does this change practice? First off, not yet, soon, not FDA approved yet. This comes into the HER2 wars, potentially displacing trastuzumab from the first line. OS is a bit immature. Please watch out for diarrhea. Have some loperamide ready. And at the end of the day, who benefits? Looks like everybody. PD-L1 less than 1% and greater than 1%. So, practice changing 2025 into 2026. Matterhorn, perioperative Durva added to FLOP, significantly improves outcomes in resectable gastric gastroesophageal cancer. Destiny Gastric 04. TDXD is clearly superior to RAM-based second-line therapy for HER2-positive, metastatic or unresectable gastroesophageal and gastric cancer. So this should really be coming in. But hot on its heels is Horizon GA01 with zanidatamab, our bispecific HER2 targeting agent, plus chemo, plus tislelizumab, outperforming trastuzumab in the first-line HER2-positive metastatic gastroesophageal cancer setting. So we had a lot to go through. I think we made it. I appreciate you guys tuning in and listening. My name is Nick Hornstein. I'm on X at GI MedOnc. I'm always happy to chat, go through studies, or talk about patients. So it's been a pleasure discussing, and I hope to see you sometime in 2026.